Welcome back to another episode of Funny Healthcare Business. I'm Christine Spraker.
I'm Dr. Aki and we're the co-CEOs of Eon. Today we have Kevin Hutchinson, man. Thanks for being here much, man. So you've known us since the very beginning.
Yep.
You are now a board member of Eon.
I am.
But previously you were involved with Medscape in healthcare, and then the founding CEO of SureScripts.
Yep.
Amongst other things, you were also with IBM and Oracle previous to being in healthcare as well too. Mm-hmm. And just a wealth of success and knowledge, and you've been awesome for us, man. And just thank you for being here today.
Well, I appreciate the invitation. This is great to do.
And here we are in Roaring Fork Valley. I just can't say enough about it. I miss it.
Beautiful Glenwood Springs.
That's right. My soul cries for Glenwood Springs and coming back here.
You want to get on that river right now.
That's right. I love that river.
Yeah.
So I used
it's
to
cold.
live.
It's cold right now, though.
It's very cold. It's definitely
Maybe
very
with
cold.
some waders and a rod.
Right.
That's right. So, funny business is what this podcast is about, Kevin. And what we're really trying to do is, learn.
Yeah.
Right. It's a podcast about learning. And for me, I've learned the most, we call it a PhD in what not to do.
Yeah.
Sometimes is more valuable than a PhD in what to do.
It's really important.
That's right.
Yeah.
And so, Christine, what do you think? I mean,
Yeah. So I have a couple questions for you. Aki mentioned you started with IBM and Oracle. You were in marketing.
Yeah.
How did you make the shift when you went to, was it Vizient?
Well, it was VHA, now called Vizient.
Okay.
Yeah,
how did you make that shift?
After IBM and Oracle. So Oracle, I had health teams at IBM, but when I went to Oracle and did corporate business development under Ray Lane and Larry Ellison, and we were working on moving Oracle from a products company to a solutions company. And so what they meant by that was, how could we have solutions, Oracle solutions, through third parties or their own, end-to-end by industries? So they looked at the energy industry, they looked at the healthcare industry, So ultimately, at that time, Larry decided that was not something he really wanted to pursue. But I learned a ton from the end-to-end opportunity in healthcare. And so I was hooked, because anytime you're a technology kind of guy, when you see that green field of an opportunity in healthcare, and this is, back in the mid-90s, that you just jumped all over it. Mm-hmm. And a friend of mine was running VHA's IT business. And VHA, now Vizient, had allocated a lot of money to make early stage investments in healthcare startups.
Okay.
And so since I just finished 9 months of evaluation of the healthcare industry and what solutions are out there and who was doing well and who were the early stage with, I actually got to put all of that to use by going over to VHA and making early stage investments, which is actually what brought me over to Medicalogic Medscape, because one of the investments we made was in Medicalogic as an early stage electronic medical record software company. And they had just gone public and acquired Medscape. And they asked me to join them as one of their executives.
And you were the COO?
I was a COO, yeah.
I mean, it sounds like a pretty simple thing where we were using paper prescriptions.
Yeah.
And look, I've used paper prescriptions when and I can't read my own writing. Right. So
I've always wondered about that.
No, it's
but it seems like something like, okay, hey, we shouldn't put this on paper with Scribble. Right.
Yeah.
And we should, have electronic prescribing.
Yeah.
It seems like a very simple, okay, that's a problem. Here's a solution. But man, you transformed healthcare in America.
That's big. That's huge.
True,
that's true.
That is a mantle.
But it is, right? I mean, if you think about it, you're the founding CEO where we were doing something so archaic that had so much error and room for error.
Yeah.
And then you turned it into something that has much more certainty and less room for error. Error was faster, more efficient, more cost effective. That's big. Yeah. That's a big deal, right? I mean, maybe you could just talk a little bit about that experience in terms of hey, here's this idea of trying to solve this thing and what it actually took to get that done.
And did SureScripts recruit you over?
So there was the two associations, the National Association of Chain Drugstores and the National Community Pharmacists Association. One represents chain drugstores, one represents independent pharmacy. It was really their idea of how can we automate the prescribing process, but they didn't really know how to, build tech software companies. So yeah, it was them that recruited me to come build this on their idea. Well, I just come out of Medscape, we sold Medscape to WebMD, we sold Medicalogic to GE, which became Centricity. And so I was kind of on the beach enjoying life. And then, they wanted someone with that level of healthcare tech experience. And so when I met with them, it was interesting because Craig Fuller, who was the CEO of NACDS at the time, and Bruce Roberts was NCPA. And I said, look, you're not going to get this done without industry support. It's just too high of a bar to kind of get people to move. It'll take a decade to get this to happen. And I said, so I'd love to meet with the CEOs of the major chains and make sure that they are committed. So
the pharmacy chains.
Yeah. So I said,
like the CVS's and the Walgreens.
Yeah, CVS, Walgreens back then, Eckerd, Rite Aids.
I remember
of the word. Yeah,
I get candy there as a kid. That's right. Like 25 cents was a lot of money back then. That's right.
So I actually hung up the phone and thought, all right, I'm never going to hear back from these guys because, the CEOs, I'm sure, aren't involved in this kind of IC and concept. Well, literally in 48 hours, not only was I on a plane headed to go meet with each of those CEOs, Walmart included, by the way, and their commitment level was huge because they knew they needed to transform a very error-prone process. And what was funny, when I started meeting with doctors about e-prescribing, they would do this every time. They would grab their pad and they would scribble on the pad and they'd hand it to me and they go, if I can e-prescribe as fast as that, then I'll do it. And I'm like, okay, let's talk about what happens when you do that. And we talked about the phone calls from the pharmacies to the doctor's office to validate the prescription.
Oh, interesting.
Right? And the doctors would always say, oh yeah, that's not that bad.
It is bad.
But who stepped in? Were the office managers and the nursing staff of the offices said, you have no idea how many calls we get a day.
This is crushing us.
Refill authorizations, illegible script, drugs that weren't on plan. And so once the doctors started understanding the challenges with that paper process, and we had the pharmacies on board, then everything else just kind of snowballed.
That's a big education barrier. We see similar education barriers where physicians have this thing like, listen, I'm doing this. It works. It's fast. It works, but they don't understand or are connecting that dot to an operational inefficiency or real problem. Man, that's a pretty big deal to try to get physicians to, have that education. Maybe you mind speaking a little bit about kind of how you got the physicians over the hump?
Well, so I just come out of the EMR world, right? So part of my career, which is probably why I got white hair at the age of 40, was because we were always doing the innovative stuff.
At least you have some hair, Kevin. I'm just saying.
So we were always trying to do bleeding edge things. So, one of the first electronic health record systems, right? And then one of the first national e-prescribing networks and other things that we've done or I've done. And when I finished the medical record world, it was stuck. Like, there's not enough value for doctors. At that time, it was just documentation of care, right? And there just wasn't enough value. So when the e-prescribing thing came up, I thought if we could actually get value by connecting all those medical record software products actually into the pharmacies and reduce those phone calls, we could actually have something that would be the first generation of transactions between providers, in this case, pharmacists and physicians. And so it was tough getting the physicians on board. We started getting larger physician groups excited about it, but it wasn't until the federal government got involved and I was doing advisory work for President Bush to roll out this idea of a national health information network, right? You remember back in those days. And it was just a framework. They weren't going to build it or roll it out, but they were trying to create a framework for interoperability. And they landed on the fact, wow, we could actually do prescriptions first.
Makes sense.
As a proof of concept.
Yeah, well, as a scaled way in which we could start doing e-commerce, if you will, in healthcare. Doing electronic transactions. The way the financial industry does every day, right? And so that was we'd already been doing claims and, bills and all of that stuff on the healthcare side, but we'd never done actual real-time business transactions. And so that's where it all came from. And that's how the doctors got on board, is once they saw the value prop in that. And the big thing was they had one screen to come where all of the refill authorization requests came from all the different pharmacies, and they could simply check a box and approve or decline and hit a button and send them all back. And when they saw that actually have that capability, they were hooked.
When you're building into a white space like this, and it's never been done before, and you have naysayers and you have the doctors and you have all of these misaligned folks.
Yeah.
First of all, what were some of the challenges you encountered outside of just the doctors and all of that? But are there any mistakes that you made that you wish you hadn't made, or that you would do differently in hindsight?
Oh, the list is probably much larger than the ones that, I'm happy that we made, because you have to learn from the mistakes. You have to kind of push yourself to the point to where you can say, okay, we learned a lot from that. Let's back up. And I think the going into it with a bit of industry support of making this happen was one of the positive things. Some of the negative things were sometimes people were wanting to use it as a competitive advantage in the market when you're trying to build a utility that's advantageous to everyone.
Sure.
That's right.
And so we made some mistakes along the way in the early days, like, well, we need to get kicked off and get started. So let's give, this entity this feature that maybe we won't offer up for another entity for a period of time. And we learned really fast on the reaction that we got from the industry, given we had their support, that wasn't going to go over well. So we backtracked on that really fast. And then we said, same price for everyone, same standards, same certification process. So we just became a utility, just like an electric utility. I used to get people wanting me to demo SureScripts. Can you show me a demo?
Oh,
we get that said all the time.
Like, you can't demo electricity, right?
Yeah.
But I could show you the end systems that are on the electricity and what they're doing with, the data that we're transferring. And so that was always interesting when people wanted to see it in action.
We get that a lot.
Yeah.
Can we see a demo? And we have an interface, so we do have a dashboard, but it's everything that's going on behind the scenes that is really what is powering.
Yeah.
What
well,
we
it's
do.
the sharing. What I love about Eon too is the sharing of the knowledge, the care paths, right? Of what, if we can bring consistency to care.
That's right.
By learning from other providers and other groups that have seen positive outcomes for those care flows, right? And those and somehow automate that by sharing of that information and data into systems they may already be using, you can really, get installed in the system, in the industry much faster.
It's a big problem sharing knowledge. Like, I get it, right? Like payers wanted specialists. I was a lung specialist. They wanted me to see a patient once, do an assessment and then create the care plan.
Yeah.
But then I was in a silo to where I never knew if the care plan that I initiated with that patient, what the outcome was.
Yeah.
Did I bring value to the patient? Was it the appropriate, decision that I made? And doctors, we're dying for it, right? We're dying for that knowledge back of, hey, did that medicine work?
Yeah.
Did that therapy work? Did that intervention work? And so it's tough to share knowledge in healthcare today.
Yep. Yeah, it is. I think it's one of the things that we still have a long way to go. We've made some progress on interoperability. It starts with standards and getting all technology companies to adhere to standards. That's how at SureScripts we established the NCPDP standard. We selected it over other standards that were trying to be the e-prescribing technical standard, but we had to choose one. And we chose that one for a variety of reasons. But then when we took it into the industry, if they have a standard in which they can all use to be able to make that exchange possible, but when you're have competing standards, technical standards, and you're trying to implement multiple standards so that other entities will connect into you, it slows everything down.
Well, that's what happened with the EHRs. Yeah. There's multiple standards. There's variations even within one EHR. They have different instances and they're all different.
Yeah, well, I was on the HIT standards committee for establishing EHR standards for federal certification. And that's a really long story of how that transpired. I didn't originally want to be on that standards committee. That committee was originally established for interoperability focus.
What year was that? Years?
That probably was 2003, 2004, something
Okay.
like that.
So before high tech.
Yeah.
Before.
Oh, interesting.
Yeah.
Oh, you probably had a hand in creating high tech then.
Well, they would come to the committee and run things by us with respect to things they were thinking about doing. But the
Interesting.
High Tech Act, was kind of in about the same time frame of establishment of those committees. There was the policy committee, and there was the technical standards committee, and I was on the standards committee, even though I'm not a technical person.
I'm just curious, what type of standards were you recommending for the EHRs at that point?
So we had to look at all kinds, right? We had to look at, lab orders, lab result delivery, right? Referral management. So what we're going to be mainly so it kind of fed from the interoperability work we'd been doing. What are going to be the exchange standards that we're going to use? Then we had to look at, there were different HL7 standards versus other standards that might compete with that. Everybody knows now the CDA, the content data architecture, something like that. But back before that was created, there was this thing called the CCR. And that was, everyone was starting to implement the CCR, but it didn't have all of the architectural aspects of the CDA, right? You wouldn't believe the conflict, because we would take open testimony at these public meetings where you'd have a CCR supporter come and testify.
Goodness.
You'd have the CDA supporters come and testify. And they were very passionate about establishing their standard as the standard that all EHRs were going to have to use. That was there was a lot of lobbying going on during those time periods, and so that all settled out with the certification of the EHRs.
It's fascinating. We implement within different IT infrastructure all the time, and nothing is the same, like Aki was saying. And whether it's a fire or HL7 or whatever the standard is, they're all different.
It's slow scale.
Yeah,
right.
It does
immensely.
It makes it longer. It makes it more expensive.
That's right.
Makes it less efficient. Makes it error prone if you don't follow a set of standards that the industry is going to use. And again, we've come a long, long way in the last 20 years of establishing what those standards are going to be and making it clear. And a lot of the noise or conflict between those standards has gone away. But as we still haven't implemented a lot of this, we don't have a national referral capability, amongst the EHRs. I wouldn't necessarily say, while we are doing lab ordering and results, it's not consistent across all of the labs. Maybe the national labs, but maybe not the local, regional hospital labs.
I mean, there's not even a consistent national provider dictionary, that has just like a phone book, right? Of docs and where their office is, what their number is, how to contact them. Yeah. Which is crazy to me, right? It's 2022.
It's crazy. Well, even the NPI, the National Provider Index, it goes usually to their billing address. So it's not even the doctor's office. It's challenging.
We don't even have a national patient identifier.
That's right.
I mean, all of the matching that we have to do for records, first name, last name, date of birth, address, previous address, et cetera, just to try to make sure that we're getting the right records tied to the right things. I mean, I know people are on different sides of the fence on this particular topic about whether there needs to be a national patient identifier or not. I'm a big supporter of it and think, we have Social Security numbers. We have other identifiers for us. I understand the concern about those being hacked and then used to get records and things but the benefit and the advantage of getting that in place
totally agree
is far outweighs the risk of for interoperability purposes and accuracy of the medical record.
Absolutely.
Right?
Well, so often we see somebody has an emergency visit in one health system, but their provider, their hometown doesn't have that health system. Sorry, this wind is causing my hair to be crazy, but those records don't match. And then that primary care provider never actually sees what that emergent record was. I
have to tell you a funny story. So I was still doing medical record software at the time this happened. We were having our first daughter. We were living in Connecticut at the time. And we were having our first daughter. We go to this hospital, not to be named. And the physician walks in, and she's great. We love her, and she did a great job. But she walks in. She's so busy. Her mind is just moving, right? She just came out of another patient. She walks in, she opens the folder, and she says, "How's your son?"
Oh.
And we go, we don't have a son.
Yeah.
And her reaction was, she goes, Sure you do.
It says right here.
Because she has a sticky note right here. This has a name and who it is. And we just paused and she stopped and she goes, oh, forgive me. Okay, I'm sure you would know if you have a son. And she pulled the sticky thing off and she put it to the side. But that was the world that we used to live in, right? Where notes were just moved around and they got in wrong chart. But we could do the same thing in the electronic world if we don't figure out this national patient identifier, a way in which we can ensure the accuracy of this medical record being combined with this medical record.
How do we overcome the silos that exist that are preventing us? So healthcare costs too much.
Yeah.
Right. We talked about some of the things that are adding to the cost of healthcare. And so, we can't afford and we don't have enough providers for an aging population and a growing population. How do we overcome the barriers to get technology to unleash that, exponential efficiency gain to actually make healthcare affordable and to improve our lives, our quality of life, and how long we can live as humans?
Yeah. Well, if I had an answer to all of that,
right? You got influence,
but I've got opinions.
Please.
I would say that as bad as COVID was for all of us, I think we learned a lot in COVID. I think what happened, we transformed in 2 years the way in which we think about home care, the way in which we think about telemedicine, the acceptance by providers and payers and hospitals on some of those technologies. I mean, remember, if you wanted to do a video conference or even for a business meeting, it was like, you should come face to face. We were flying everywhere. Everything, business, healthcare was transformed to start using different technologies. And the reason I bring it up for the question you're asking is because the efficiencies we get from those technologies, the increase in touch points with patients who can't come into the office, taking care to them, either through those teleconference videos or through home care organizations, it transformed not only the efficiencies, but the quality of care that we could start delivering to patients without always thinking about it's inbound into a physician's office, it's inbound into a hospital, and ultimately those patients ends up in an emergency room where it's the highest point of care delivery is if they end up in an emergency room.
The highest cost.
Right. Yeah. And not necessarily the highest quality.
Yep.
Yeah. So increasing the access and then the adoption of the sector is what happened through a pandemic. But let me tell you this. I don't want to go through another pandemic.
It's not the way we should learn, right? It's
That's
definitely not the way we should learn. But other industries have gone through hard times. Financial industry has gone through really difficult times, and new tools come out to help manage risk, financial risk when they go through these times. And so we went through a really difficult time, still are, and the health risk had to respond with new tools to help manage that risk, but improve the cost so we can improve the quality. And if you can expand those touch points and you can enable physicians to be able to, it's not just the single doc either, right?
Agreed.
It's care teams.
That's right.
Because that also was a different mentality. There's not one physician is the captain of the ship, but you have a whole care team around you that is part of taking care of that patient. And that's critically important when we start expanding beyond just having them come into the exam room to see a doctor, is that part of that care team is outbound engaging with those patients.
So let me ask you this. You mentioned you were on the committee for the standards and high tech. What role does government play in all of this? Because if without the regulations that protect electronic personal health care records, things could go rogue, but it also can stifle innovation. Yeah. So what is government's role?
Well, let me go on the record of saying I'm not a huge fan of government involvement in private markets. And so I was even though I was on 2 advisory committees for the federal government, I was there to make sure that there was balance between the role of the government could play versus the role that would be disastrous if they did play by getting involved. And I was really impressed by both the Bush administration as well as the Obama administration that they both were trying to say we are not trying to actually get into the industry. Now, we went a little further with mandating EHRs and then funding that.
Big time.
That was a stretch, and there was a lot of controversy over that. But it did get EHRs installed. It did digitize the data. We had to go through multiple, as we predicted, we're going to go through cycles. Now we're going to get EHRs installed, and they're going to get ripped out, and new ones are going to come in behind them, because the way in which we had to get deployed and the timeline we had to get it deployed was difficult. But in the case of healthcare and the government role, it's different than any other industry, right? Versus finance or anything else, because the state and the federal government are the largest payers in all of healthcare, right? You've got Medicare and Medicaid. And so you've got state funding on Medicaid along with federal, and you've got federal funding with Medicare. And so if you take the amount of money spent on patient care for Medicare and Medicaid, it far outweighs private insurance. So their role as a payer is important. And so when they are paying the bills for patient care, just like if they were talking to an Anthem or to an Aetna, or in some cases, they're not the provider of the care, but they are establishing state or federal backed sponsored places that would provide care for people who may not have insurance. So to some degree, they are funding some of those things to take place. So their finger involvement in the healthcare industry, very, very different than any other industry because of how much money, our tax money, goes toward taking care of patients.
You know, we talk about taxpayer money all the time at Eon. Right. And, you know, our mission is to make patients healthier and healthcare affordable. And it's, you know, it's sad because like the second portion of our mission either gets like laughed at. And when I say laughed at, it's not because like it's funny. It's just that people don't believe that healthcare can ever be affordable. And why are you guys?
And how can Eon do that?
Right.
But it makes sense. I mean, you know, George on our previous episode was talking about, with zero-sum game. I brought that up, right? Like healthcare being a zero-sum game. But, you know, to me, government may have to step in. You talked about this, like the conflict at SureScripts with competitive advantages. To me, that's what happened in EHRs with the standards, where like competitive advantage of one standard allowed them a moat for a certain period of time in the industry, right? And now that has to be unraveled. Do you think that the government should take a stronger hand in unraveling that? Or is it, you know, how do we do that?
I think they have to take a stronger hand. And I haven't seen as much momentum as we had in years past around still driving interoperability requirements as an example. And we saw EHRs, certain vendors oppose interoperability.
For sure.
Right? And we saw them oppose access by patients to their data, which was really shocking. Like, what are you nervous about?
What's your fear?
Right.
Data is the moat.
Right.
Data is the moat.
Because the competitive advantage, right?
That's right.
And if they can get larger and have their own customers share data amongst their own systems and not have to share it with competitive systems, then they can grow faster and dominate. And I think that's starting to get rolled back a bit now that some of the interoperability requirements, even the ones just of late that went in, that now require patient access to certain data. That was years and years in the making, and now it's in effect, where you have to require that patients get access to their own data.
They ultimately own their data.
It's our data.
Yeah.
You know, if it's your banking data, it's our data. If it's your medical record, it's our data, right? You want your bank owns it as well. Your doctor owns it as well. But at the end of the day, you know, you have to be able to provide that. And you should be able to be required to provide that to all of a patient's physicians, whether they're in the same hospital system, or if I choose as a patient to go to a doctor at a large health enterprise and then another physician, a cardiologist over here that might be affiliated with someone else, they ultimately have to decide where they're going to get their best care. Now, most of those enterprises are trying to grow and have a full suite of clinical services that keeps a patient within their enterprise. And that's great, as long as they can coordinate that care for patients and drive better outcomes.
So I think we have one final question for you. You have such a vast experience over the past 25 years. you pretty much get your pick of what to work on now. So what projects are interesting to you currently, and where do you see the next 10 years in health tech going?
Well, I'm a glutton for punishment.
Aren't we all?
So I love innovative things. I love things that are actually making a difference in healthcare. You know, I may have been part of a wonderful team that built one of the very early stage electronic health records back in the mid 90s, right?
Yeah.
But that's different now, right? So that's not, to me, it's an EHR is not necessarily innovative.
Sure.
Unless they're doing some other interesting things, like what Oracle is now trying to do with EHR systems, which is going to try to take it to a whole nother level on use of data, as an example, right? But I like leading edge things that are actually bringing consistency to care and are driving better outcomes for patients. The one area that just still we're not where we need to be is patient engagement.
Absolutely.
Getting patients to be involved in their care, right? And I think we tried this years and years ago. I was very excited about personal health records. Remember that?
Oh, yeah.
Billions of dollars went into the development of personal health. You could have a thumb drive. You could have it, right?
On your phone, on your smartphone.
Right?
Yep.
And it just went away, right? Because they couldn't get patients to really want to get engaged and really want to get to their data. Now generations have come along and people are starting to change that mentality, right? But we don't, now the EHRs say, well, we have our own personal health record and you can access it through the EHR. And it's okay, but I wouldn't say that we've seen anything blow away like, this is where I engage with my physicians. This is where I engage with my data. This is where I take care of my health, right?
And it's portable and I can take it to that other system.
Right. And it's surprising we have to do this, but we still need to incentivize patients to want to get engaged, right? And if you think about, I'm not suggesting this because people will get upset about this, but if you think about car insurance, right? If you choose to be a bad driver, if you choose or you have lots of accidents, you're going to pay a higher premium, right? In healthcare, for the longest time, everybody kind of paid, you were within this range, within this risk. And then smoking came along and people could charge more of a premium if you were a smoker. And people could and so that made people get more engaged in when you start touching their pocketbook, right?
Yep.
I'd rather it not be, a stick.
Yeah.
It should be a carrot. But how do we get patients to really want to engage? They put way too much pressure on physicians sometimes. Like, well, you're supposed to have all the answers, doc. Why do I need to do?
Yeah.
Right.
They want a pill instead of lifestyle modifications.
Right. Exactly.
But then there's also, patients don't act like consumers.
Yeah.
And like if I go to a dinner and I pay $100 for a dinner and I don't get $100 worth of value, guess what? I'm not coming back to that restaurant, right?
Right.
But patients, they go to a hospital, maybe they have a bad experience or they don't have an optimal, hey, listen, they're still going to go wherever their insurance tells them to go no matter what. And so the restaurant or the hospital in this circumstance has no motivation to really improve where they're weak at in terms of that patient engagement layer.
That's changing, right?
Yeah, agree with
now
that.
Value-based care is coming along.
Yep.
So we've played with this forever, right? So way back when, 80s, 90s, they had managed care and the health plans were actually trying to do this, right? And then everyone got upset because the health plans were denying way too many services, right? Who are you to tell me? And so as the years have gone on, accountable care organizations, value-based care contracts, managed care organizations, they all go under different names, but they're all the same. We're moving more financial risk to the providers, right? To the health systems. And if you think about it, the eye-opener was COVID. The insurance companies, the health plans, these are publicly traded companies. So you see the data. They made billions of dollars during COVID because premiums were coming in, but services had gone down, right? Elected services, right? That aren't necessarily elections. They put off surgeries. And so there was so much activity going on with the taking care of COVID patients and so much other, not outpatient care going on or other things like that, that the insurance plans made a lot of money. Why? Because they were taking financial risk for patient care. The services and utilities of those services goes down. So therefore their margins go up. Well, provider organizations looked at that during COVID and said, we can't survive another
Right.
downturn like that. They need to be paid for taking care of populations of people.
Agree, man.
Whether they're utilizing services or not utilizing services, which is what a health plan does. Health plans are very supportive of this too. They're moving the risks. You should be making the decisions, provider, and you should be getting rewarded for making better care decisions if you're improving outcomes. You'll lower cost, improve outcomes. And so now that we're moving in that direction, and 70% of all Medicaid patients are under full risk contracts, but by the health plan, being paid by the state to take full risk on those patient populations. 48% of all Medicare patients are on full risk contracts, right? Now we're moving those type of provider services to the private industry. We're still in single digit percentages.
Yeah, I think we did an analysis about 8% of our clients are actually on some type of value-based. To me, it's not fast enough.
Yeah.
There's a lot of waste. There's a lot of unnecessary tests and exams and procedures that are ordered all of the time because the incentives just don't align yet.
Right.
So that's a huge
It's a gap.
That needs to be solved for.
But it's probably, if you go back and just look at the last 2 or 3 years, it's probably doubled in penetration over the last 3 years. Even though it's still in single digit percentages, in 2020, it was the first year that we actually paid out more in risk-based arrangements than we did in fee-for-service. First year. So only 2 years ago did we finally surpass, because remember, most of healthcare is tied to Medicare and Medicaid, right? When you have 70% of Medicaid patients under full risk contracts and 48% of Medicare patients under full risk contracts, then now we have surpassed payments made based upon full risk versus fee for service.
I don't have a question. I was going to bring up the walk up song.
Oh,
we forgot last time, right?
I know.
What the heck, dude? we let George slide.
We let George slide.
That's right.
We've got a couple questions that we're going to ask our guests, and so
So first of all, man, you've been immensely just
a huge mentor.
Just a huge mentor. It's been, like, our success has really hinged on a lot of your involvement with Eon, man, and thank you so much for that as well too.
I appreciate you saying that.
Thanks for choosing us.
Your team is amazing, and what you guys are doing
They're
as a
awesome.
product is just amazing. So it's a pleasure to be a part of it.
But you've made yourself available to us too, and
It
that's
helped us a lot.
really helped us a lot.